what's your approach if somebody does have, say, not just hepatitis B surface antibody, which is more consistent with the vaccination, but perhaps hepatitis B core antibody positive as well, suggested that they've been exposed before? How do you approach that patient if you're thinking about DARA?
That's important. And I think on a patient's list, sometimes they don't even know they were exposed and actually have the actual virus themselves. So one is explaining to them that they were probably past exposed, that they never knew and had any symptoms from it. But we would treat them with upfront medication, but it would not hinder us from treating them with the daratumumab. Another factor with daratumumab, and it's interesting enough, and when you also mentioned in combination with other drugs, is that besides hepatitis B, it actually can reactivate the herpes zosters or shingles vaccine. So patients should be put on an antiviral medication prior to starting the drug itself. And if they are in combination with the IMiDs, you would want them to be on some type of baby aspirin or something a little bit stronger.
Yeah, and I think just going back to the hepatitis point, I completely agree. If somebody's been exposed to the hepatitis and is about to start DARA, we can start drugs like tenofovir and entecavir, depending on your local hepatology preference, to suppress the reactivation of hepatitis B. But the other thing that's important is to also monitor the hepatitis B PCR to ensure that we're staying ahead of that. And I think maybe, Danny, can you speak to the ways that we've kind of at Mount Sinai, because one might forget to order the type-in screen or do the hepatitis serologies, some practical recommendations for those in the community of not forgetting to do those things?
I think one of the challenges is whether you're using paper versus electronic record keeping or developing of treatment plans electronically. So at Mount Sinai, we have incorporated in all first use of daratumumab that they have the hepatitis serology panels drawn plus a type-in screen as a control factor. We also have, as a practice, have initiated, whether we do it every 6 months or to 1 year, we'll recheck their hepatitis. If they are just antibody surface, we will recheck them within a year. But if they do have a positive, we'll monitor them every 6 months to make sure that they is under better control.
And then clinical trials, it's actually every 3 months, so hepatitis B PCR. So one other, I think, relating to your testing, the question is if a patient, let's say, has been getting daratumumab, but they have an emergency, that let's say they may be in a car accident and show up at an emergency room, or they've started DARA at an outside hospital and are coming to you for subsequent care. It's important that we know how to deal with that, because if you don't have that baseline type-in screen pre-DARA, some of the strategies to deal with that are you can use trypsin or other enzymes to strip away the DARA and then type the red cell without the DARA coating, keeping in mind that it can also denature the KEL antigen, so you have to give KEL negative blood. But also at baseline, sometimes some centers do full genotypic or phenotypic characterization of the red cell.